Welcome everyone to today's webinar hosted by the Postpartum Resource Center of New York and the Schuyler Center for Analysis and Advocacy. I'm Sonia Murdoch, Executive Director at the Postpartum Resource Center of New York. And at this time, I'd like to introduce Brittany Eskew.
Hi, good morning. Welcome, everyone. I'm here on behalf of Bridget Walsh and the Schuyler Center for Analysis and Advocacy this morning. We will begin in just a few moments, but in the meantime, in order to get to know our audience a little bit better, you will see 3 poll questions appear in just a moment. Please note that any poll questions you decide to answer today are optional, and if you do decide to participate, they will be anonymous as well. The results of those polls will also be displayed after we close out the poll. So I will go ahead and bring up that first poll question. It's actually 3 poll questions. And I'm going to leave the poll up for about just a minute. I want to make sure the people who are here can get a chance to answer those questions. We still have some folks coming in too. Great. We have a lot of people coming in right now. Great. Great, I'm going to leave it up for about 20 more seconds. Thank you again for answering these questions if you choose to. All right. Okay, great. So I'm going to go ahead and close out this first set of poll questions. Thank you to everyone who answered. And I will go ahead and share the results. Again, these are all anonymous, and we can get an idea of what our audience makeup looks like today. Great. All right. Again, everyone, I'm Brittany Eskew. Again, I'm here on behalf of Bridget Walsh with the Schuyler Center for Analysis and Advocacy. I am a research associate there. We're excited to offer this presentation and the MomD webinar series in collaboration with the Postpartum Resource Center of New York. The Schuyler Center is a statewide nonpartisan advocacy organization primarily focused on improving policies for those living in poverty, particularly children and families. The MomD, or Moving on Maternal Depression work, is part of our continuing efforts to connect and improve care and resources for pregnant and parenting women and their children. Moving on Maternal Depression was part of a national learning collaborative to advance policies that improve prevention, screening, and treatment with an emphasis on racial equity and culturally relevant practices in policy systems management. Here in New York, we expanded that focus to include maternal mental health more broadly. While our national project has wrapped up, we hope to develop a state-level learning collaborative that can share best practices and information on maternal mental issues here in New York. And one of those projects for the MomD initiative is this webinar series. Again, as a research associate, I am here on behalf of the Schuyler Center. I will be available in the chat for any technical questions or any issues that you may have during this webinar series. And I'm going to go ahead and turn it over to Sonia, who will introduce the Postpartum Resource Center and our speaker for today.
Thanks, Brittany. Hi, I'm Sonia Murdoch. I'm the Executive Director of the Postpartum Resource Center of New York. The Postpartum Resource Center helps New York State moms, dads, and families get to the help they need for perinatal mood and anxiety disorders since 1998. Our statewide toll-free helpline is available 7 days a week with additional support from Moms on Call and family telephone support. Online, we have free access to our statewide perinatal mood and anxiety disorders resource directory. We also offer education on perinatal mood and anxiety disorders through our training institute, including our Circle of Caring support group programs and various initiatives such as Project 62, the Lisa Mary Riley Visioning Educational Series, and Take Care of You. If you have any questions regarding more specific services we offer, please let me know at the end of the presentation today. This webinar is approved for one continuing education unit for New York State licensed social workers and New York State licensed mental health counselors at the cost of $15. Helping Hand Psychotherapy is recognized by the New York State Education Department's State Board for Social Work as an approved provider of continuing education for licensed social workers and by the State Board for Mental Health Practitioners as an approved provider of continuing education for licensed mental health counselors. Brittany at this time will post a link in the chat for those who would like to take part in the CE unit. So before we introduce our speaker, we'd like to ask 2 more poll questions. And remember that these questions are optional and anonymous, and the answers to these questions will be displayed for the audience to see. So thank you for answering them if you choose to.
Thank you, everyone. I will leave these poll questions. There's just 2 here. I'll leave these up for about a minute to give those of you who choose to answer them some time. Thanks, guys. I'm gonna leave it up for about 10 more seconds. We still have some folks coming in too. Okay, great, thank you. I'm going to go ahead and end this poll now and share the results. I'll leave these up for just a few seconds here so we can get an idea of what the audience makeup is. Great, thank you guys so much.
Thank you. I'm excited to introduce our speaker today, and it's a great pleasure to welcome Dr. Kelly Ramsey here. And Dr. Kelly Ramsey is an internal medicine physician who's treated substance use disorders since 2004. She is board certified in internal medicine and addiction medicine. She worked as medical director of an academic-centered OTP in the South Bronx before working for nearly a decade for a large federally qualified health center in the Hudson Valley, where she created and grew a medication-assisted treatment program for opioid use disorder and AUD to 10 sites and 1,500 patients. Dr. Ramsey currently works as the Associate Chief of Addiction Medicine at New York State Office of Addiction Services and Support, also known as OASAS. Dr. Ramsey has provided expert advice to the New York State Department of Health AIDS Institute by serving on numerous committees for over a decade. Dr. Ramsey was the recipient of the New York State Department of Health Commissioner's Special Recognition Award for contributions to drug user health in New York State in December 2018. Dr. Ramsey serves as the HCV and drug user health champion for the Capital District for Mount Sinai. Dr. Ramsey is the president-elect for the New York Society of Addiction Medicine Board of Directors. So welcome, Dr. Ramsey. And at this time, I invite you to share your screen.
Great, thanks so much. Let me just bring my slides up. One moment. Okay. All right. So let me just transfer to slideshow, and I'm going to go ahead and get started. And it's a long presentation, so I'm going to move very quickly through my slides, and you guys will have access to these afterwards if I don't get to cover everything as thoroughly as I would like to. So I'm going to focus on opioid use disorder in women with a focus on pregnant and parenting persons. looking at stigma and treatment options. So I don't have any significant financial disclosures. So for the learning objectives, I'm going to summarize the epidemiology of substance use disorder in women with a focus on opioid use disorder, discuss stigma towards women who use drugs, particularly pregnant and parenting persons, and discuss the role of language in stigmatization, discuss harm reduction practices and trauma-informed care to engage persons with substance use disorder more effectively and sensitively, and discuss medication for opioid use disorder, or MOUD options, and best practices in pregnant and breastfeeding persons. So first, let's look at the epidemiology of substance use disorder in women. So I'm not going to go through every detail on this slide, but this is not the first time we have had an opioid epidemic among women in the United States. Actually, the first opioid epidemic was in the early 1800s in the United States. At that point in time, heroin-based and morphine-based products were sort of over-the-counter, unregulated medicinal tonics that were marketed specifically towards middle class and upper class white women and children for various medical conditions. Interestingly, it was assumed that women were sterile who were using opioids, and so they did not consider that they would ever become pregnant and have potentially infants that were affected. However, the first birth of a neonate with what we would now call NOWS, or neonatal opioid withdrawal syndrome, was in the late 1800s, and they had no idea how to treat it. In 1903, they actually gave an infant morphine for the first time to treat NOWS, and it was an effective treatment, and that is still the treatment today. So we're going to look really quickly at the epidemiology of opioid overdose deaths. So this is pre-COVID-19, and on the left-hand side, you can see probably what is familiar to many of you, looking at opioid overdose deaths between 1999 to 2019. And you can see from 2013 onwards, there's a very significant increase in synthetic opioid overdose deaths, which is due to illicitly made fentanyl and its analogs. On the right-hand side, you can see that there's been a substantial increase in opioid overdose deaths in women of childbearing age between 2007 and 2017. Particularly, you can see that increase is due to synthetic opioids, again, due to illicitly made fentanyl and its analogs, and due to heroin. So there's a pretty big overlay between mental health issues and substance use among women greater than or equal to 18 years old. In the middle, you can see that about 4.6 million or 3.6% of the population 18 or older have both a substance use disorder and a mental illness. So obviously there's a large population with each individual diagnosis that do not have that dual diagnosis, but it's important to understand that many of the patients that you encounter will have dual diagnosis of mental health and substance use disorder. So this is looking specifically at misuse of prescription opioids by women. And on the left-hand side, the point that I want to make is that most people acquire misused opioid prescription pills that are either bought from, given by, or taken from a friend or relative. So that's just important to be aware of. And then on the right-hand side, you can see that by and large, the most misused opioid is buprenorphine. And I'm going to talk about buprenorphine later. And I think what's really important to recognize in that slide is that buprenorphine is used by people who often either can't or won't or are unable to access treatment for their opioid use disorder. So when people are acquiring buprenorphine on the street, they're doing it to either treat their opioid withdrawal symptoms, or they're doing it to manage their self-diagnosed opioid use disorder. So people who are opioid dependent or opioid tolerant do not get any euphoria from buprenorphine because of the pharmacology, specifically of the medication. What the medication does is it blocks their opioid withdrawal symptoms, and it decreases cravings to use. So I think that that's really important for people to understand. So what are some of the consequences medically that we see of opioid use in women? Well, I think one thing that's important to know is that the ratio of male to female use of opioids has really become 1-to-1 since the 2010s. That's very different from the ratio of male to female 4-to-1 for heroin use, for instance, in the 1960s. The other thing is that women are at higher risk of contracting hepatitis C and HIV with IV heroin use, probably because they are more likely to share with other people or share needles with their male partners when they have male partners. Women are also more likely to be prescribed opioids for pain than are men, and they are more likely to report chronic pain. Women are less likely to decrease of prescription opioid overdose or really any opioid overdose than men. However, the increase in opioid overdoses among women due to prescription meds has increased at almost 2 times the rate that it has in men between 1999 and 2016. So again, that rate has increased almost 600% in women during that time period. And also women are more likely to die from opioid overdose because they're less likely to have their overdose be intervened upon and given naloxone than are men. So these numbers are looking at opioid use disorder among women and MOUD, or medication for opioid use disorder. And so on the left-hand side, if we look at sort of the childbearing age group, so you can see that there's high opioid use disorder among 18 to 25-year-olds, as well as 26 and older. Unfortunately, the 26 and older is not broken down into smaller increments. On the right-hand side, we can see that there have been gains as far as the number of persons still on MOUD currently. However, the gains are not what we'd like to see because it is the standard of care for opioid use disorder, and still the vast majority of people are not on medication. So again, addressing the point about co-occurring substance use disorder, and mental illness or mental health diagnoses in women. So it's very common to have comorbid depression or PTSD and a trauma history. So again, some differences between males and females with respect to having comorbid mental health issues and substance use. So depression increases the risk of substance use initiation, especially in adolescent females, whereas in males, often it's more related to conduct disorder and ADD. And adolescent males tend to drink to have fun, and adolescent females tend to drink to cope with depression. So that's often, again, where people's initial experimentation with substance use starts. Adult women report using substances to manage their negative affective states, so again, their depression. And adult women with substance use disorder have higher prevalence of depression and anxiety disorders than do men. And again, treatment-seeking women with SUD are more likely to be diagnosed with multiple co-occurring mental health diagnoses than are men. So with respect to PTSD and trauma, they're extraordinarily common in women with substance use disorder. Women are far more likely to report trauma histories and post-PTSD than are men. Often the PTSD in women with substance use disorders is a result of childhood. And when I say that, I mean pre-adolescent sexual trauma. Which is very highly correlated with substance use disorder development. I'm not going to go into the rest of the details there, but again, you'll have these slides afterwards to reference. So again, looking at this group and looking at co-occurring disorders, we can see on the left-hand side that there's a high degree of suicidality among adult women 18 years or older with co-occurring disorder. So serious thoughts of suicide more so than making a plan or making an attempt, but I think that's important to recognize. And again, despite these high co-occurrence of these disorders, there's high prevalence among women, but there's high treatment gaps. So the vast majority of people with a substance use disorder, for example, never get any treatment for it. So, and when we're talking about the population that actually gets treatment, it's about 11 to 12% of the population out of 100. So the vast majority don't. With respect to mental illness, the stats are a little better, but they're still not very good. So about 50% of people with a mental health diagnosis don't get any treatment whatsoever. So we really need to work on the treatment gap that we unfortunately see. So I'm going to talk a little bit about specifically substance use in pregnant persons. So on the left-hand side, you can see past month substance use among pregnant persons, looking specifically at illicit drugs, marijuana, opioid, cocaine, as well as tobacco and alcohol. And you can see, there's a little fluctuation between the years, but it's pretty consistent with much higher use of tobacco, alcohol, and marijuana than other substances. And if we look at marijuana use by pregnancy status, again, a little bit of fluctuation over time, you can see it's far more commonly used in non-pregnant women than it is in pregnant persons. This is looking at daily or almost daily marijuana by pregnancy status on the left. And again, you can see that it's more commonly used in non-pregnant persons than in pregnant persons. So how about looking at pregnancy and prescription opioid misuse among SUD treatment admissions? So on the left-hand side, that we can see that the increase has occurred pretty consistently since the 90s of admissions for pregnant persons who report using marijuana or report using another substance. So that's on the left-hand side. And again, this graph only goes through 2012. If we look at it through present day, which I was not able to find one to demonstrate that, it continues to rise, particularly with increased legalization, et cetera, of marijuana. And then opioid use disorder rose more than 4 times among pregnant persons between 1999 and 2014. This slide is looking at the prevalence of opioid use disorder per 1,000 delivery hospitalizations, and you can see that that's gone up very starkly since 2004. And then on the right-hand side is a map of the United States, again, looking at it by number per 1,000 hospital deliveries. And you can see in the states with darker blue that that's where it is the most prevalent. So some things to kind of understand about the population of pregnant persons and substance use. So what naturally happens with most people who find out that they get pregnant and they are using substances, whether it's alcohol, tobacco, or illicit substances? So what happens for most people is that when they find out that they're pregnant, they decrease their substance use with whatever substance it is that they're using progressively by trimester. And that's pretty common, and that is what usually happens. So the vast majority of pregnant persons are motivated to maximize their own health and the health of their developing fetus. So those pregnant persons who are unable to cut back or quit using likely have a substance use disorder. What defines a substance use disorder is a compulsion to use over which there is no control. So in other words, they're not choosing to continue to use, but they actually are unable to stop using. So continued use in pregnancy can indicate a substance use disorder and would be something that would need to be pursued more with the pregnant person. So what about some stats on maternal mortality in the US? So unfortunately, the maternal mortality in the US is much higher compared with other industrialized countries. You can see that with the graph on the left-hand side. So the US is all the way down at the bottom with the highest rate of maternal mortality compared to other developed countries. On the right-hand side is maternal mortality due to fatal overdose. So unfortunately, one of the major causes and one of the rising causes of maternal mortality, which is again measured throughout pregnancy and up to 1 year postpartum, is due to unintentional opioid overdose. And you can see that that risk increases particularly after delivery has occurred. And so that's a particularly vulnerable time in the life of persons who are postpartum with opioid use disorder. So it's really important to make sure that that treatment continues consistently and that the person has access to naloxone in case of an unintentional overdose. So I'm going to go pretty quickly over this slide because this is a very detailed slide and I've addressed some of the the issues in the previous slides. So this is talking about vulnerabilities for developing substance use disorder. So I think the really important thing to recognize is that genetic predisposition accounts for about 40 to 60% of the risk a person has for developing a substance use disorder. So higher than any other risk is the genetic predisposition. So it doesn't matter which substance we're talking about. If there's any substance use disorder in a family tree or any gambling disorder, eating disorder, et cetera, that's going to put someone at an increased risk for developing a substance use disorder. Additional risks include having a concomitant mental health diagnosis, so particularly certain diagnoses like bipolar disorder, any anxiety disorder, as I talked about already, major depression, also ADHD, ADD, though again, that's more influential in males and adolescents than in females, and then specific personality disorders, so borderline personality disorder, antisocial personality disorder. A history of trauma and or abuse is ubiquitous in patients with substance use disorder. And for females, it's particularly pre-adolescent sexual trauma. And for males and females, and often you have to prompt males to get this history, is being a victim of violence or a witness to violence. So violence in the home growing up, violence in through experiences they've had related to their substance use disorder, sexual violence, et cetera. Often folks have poor coping mechanisms, and perhaps initially they were looking for escapism. Impulsivity plays a role in the initiation of substance use and is particularly associated with bipolar disorder and borderline personality disorder. Again, initially, sensation or novelty seeking can play a role early in initiation of substance use. And then environmental triggers and sensory cues are extremely important as triggers to use or resume use. So if a person shows up at someone's door with a bag of heroin visually in hand, often the person's brain kicks automatically into a mode, and it triggers them to use. If they hear a song, have a smell, et cetera, run into their former dealer, et cetera. The sort of formal definition is a lack of homeostatic reward regulation or reward deficiency. So when your brain becomes primed with substances very early in your life, what happens is that the brain actually anatomically rewires pathways to reinforce that orientation towards pleasure, and it changes the balance of neurotransmitters. So when you use any kind of addictive substance, but particularly opioids, methamphetamine, et cetera, you get a surge of dopamine in your brain, which is associated with pleasure. And there is nothing natural that mimics that. So whatever dopamine surges you get from sex, from food, from anything that brings you pleasure does not compare on the scale of what drugs do in the brain. And so our frontal lobe, which is how we make executive function in our lives, how we weigh consequences of our actions, how we make informed decisions. The frontal lobe in our brain does not finish developing until we're 26 years old and approximately. And so when people start using substances early in their lives, 10, 11, 14 years old, and you're reorienting those anatomical and physiological pathways, you really are fundamentally changing your brain. So the role of trauma plays a huge role in substance use disorder, as I mentioned. And so if we look at an ACE score, which is adverse childhood experiences and outcomes, and this can be abuse, neglect, household dysfunction, this leads to actual physical consequences and to increase in risk for developing substance use disorder and mental health diagnoses. So what is trauma? So it's exposure to actual or threatened death, serious injury, or sexual violence. And this can be directly experiencing the event, witnessing in person the event occurring to somebody else, or learning that such an event happened to a close family member or friend, or experiencing repeated or extreme exposure to aversive details of such events, like a first responder. And those effects lead to the consequences on the right-hand side. So if we look at the population of pregnant persons with substance use disorder, you see many of these comorbidities and situations that I've mentioned thus far. So if we look at pregnant persons with respect to mental health, 2/3 will have co-occurring mental health diagnoses, including depression, generalized anxiety disorder, and PTSD. The majority will have a history of sexual trauma. So as I mentioned, pre-adolescent sexual trauma or physical trauma. And there's a high level of intimate partner violence in the last year. 80% of the pregnancies are unplanned, and there are low rates of contraception use. When somebody is actively using and has a substance use disorder, using contraception is going to be very low on their priority list. They often have other substance use, so tobacco use at rates of greater than 90%. And then there are problems with social functioning. They often have inadequate social support, social isolation, and exposure to poor parenting models. So I'm going to move into the next section on stigma, language, and barriers to care. So there are many barriers to substance use disorder treatment for women, and they experience more treatment barriers than men do. They often experience increased social stigma and discrimination, and that's the #1 reason why women don't seek substance use disorder treatment. They're less likely to be screened in primary care and mental health settings for substance use disorder. There's lack of treatment services for pregnant persons, lack of childcare services for parenting persons, economic barriers, lack of insurance, lack of transportation or funds for transportation, trauma histories, and intimate partner violence, which may be preventing them from seeking treatment. So we need to talk about stigma for a few moments. So healthcare providers have levels of stigma and bad feelings towards people who use drugs, in part from derogatory or dehumanizing language that is commonplace in healthcare settings. And studies indicate that the language used corresponds to providing poor treatment. So what we say and how we say it very much matters. So on the right-hand side, I'm going to talk about this first, and then I'll talk about on the left-hand side. So these are just some examples of words that we should not be using in any setting, period, but I mean particularly in healthcare settings. So think of it as getting rid of the A words. So we should not be using the word abuser, substance abuse, addict, alcoholic, etc. We want to label people as people first and not define them by whatever their substance use disorder is or whatever their behaviors are. So a person with bipolar disorder, a person with opioid use disorder, etc. We should never be using the terms clean or dirty to describe people or their urine toxicologies. For example, we would not tell a person with diabetes that their urine is dirty with glucose. But somehow it's acceptable to use this language with substance use disorder. And the point is it's not acceptable. So again, we should be describing toxicology results by what they are. It's either expected or unexpected, appropriate or inappropriate, but again, not clean or dirty. People themselves may refer to themselves as clean or dirty. And again, a lot of that is internalized stigma that they've heard from others. And I think it's really important that we not use that terminology. So if a person is in recovery, they're in recovery, or they're not using currently. Or if a person is using currently, then they're actively using. There's a little more controversy on some of the other terms I have here. So lapse, slip, relapse are a little controversial. So again, just say factually what's going on. The person has resumed use or the person is not using. So again, terms that are morally neutral. On the left-hand side, they actually did a study with people, and they looked at how negative terminology or derogatory terminology such as substance abuser elicits bias. And so what they found is when they used language such as substance abuser, people were more likely to be punitive in their viewpoints of the persons that were being discussed, and to think that those persons should be punished as opposed to thinking that they were going to succeed in treatment, for example. So stigma has always been with us with respect to particularly parenting and pregnant persons and substance use disorder. So what did it look like in the late 80s and early 90s? it was crack babies. So for example, crack babies, the worst threat is mom herself. So again, pitting mom against her fetus or mom against her child. And then a more modern version is children of the opioid epidemic. So these are just some headlines: pill popping mamas, many pregnant women take opioids, number of mothers using opioids while pregnant is rising in Tennessee. So again, news's job is to sell newspapers or to sell their shows, et cetera. So they're going to be inflammatory, but we don't want to mimic that language. So here's another one: a parent's heroin addiction, a newborn's death sentence. So that's a complete misrepresentation of neonatal opioid withdrawal syndrome. So it is not a death sentence for a newborn, and there is no such thing as a drug addicted baby. So again, really important that we do not use that language. So what is happening with a neonate who has NOWS is that they are experiencing physiological withdrawal to an opioid. It's predictable and it's treatable, and they're not long-term consequences. In order to have an addiction, as I said, it requires a compulsion to use over which you have no control, which obviously a baby does not have that. It also pits the parent versus the child rather than seeing the birth parent and the child as a dyad. This is super long, so I'm not going to read this. So you will have the slides, you can go back and read this. But again, this is coming from ASAM, so the American Society of Addiction Medicine, and it's really important to recognize the role that stigma plays in pregnant persons not seeking care. So that could be both prenatal care and substance use disorder treatment. And what we know is that without prenatal care, the outcomes for that pregnant person and that fetus or neonate will be far worse. So substance use disorder treatment during pregnancy, as I've said, most people in general, whether they're pregnant or not, don't get treatment for substance use disorder, but it's terrible as well for pregnant persons. So if we look at stats here, pregnant persons are twice as likely to get treatment than non-pregnant persons. However, again, it's only hitting a very small proportion of the population. So this is referring to what I was saying before. So if we look at the outcomes for people who are using drugs when they're pregnant, who receive prenatal care and don't receive prenatal care versus a non-drug using population, let's look at those outcomes. So if someone is actively using and they receive no prenatal care, then it's likely that 48% of them will have an infant with low birth weight outcome. However, if that person is using drugs and gets prenatal care, even if they're still using drugs, their outcome is the same as a person who is not using drugs and has no prenatal care. And you can see that the difference is actually very little between that person who's not using drugs and has prenatal care. So the key here is, even if someone is actively using drugs, it's very important that they engage in prenatal care. So we need to decrease the barriers to them doing so. So how does stigma lead to punishment of persons of childbearing age? So there's a pretty clear line from stigma to punishment. So stigma, again, means associating people disgracefully who are with a particular group, quality, or person. That can lead to dehumanization, then to discrimination, prejudice, and punishment. So there are actually 3 states in the United States that require civil commitment. So they incarcerate women who are using drugs during their pregnancy until they deliver. So obviously, that is not a good outcome. So 23 states in the District of Columbia consider substance use during pregnancy to be child abuse under civil welfare statutes, and 3 consider it grounds for civil commitment. 24 states in the District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 states require them to test for prenatal drug exposure if they suspect drug use. Only 19 states have actually created or fund drug treatment programs that target pregnant persons, and 17 states in the District of Columbia actually provide priority access, and only 10 states prohibit publicly funded drug treatment programs from discriminating against pregnant persons. So we have more states that are doing discriminatory things than states that are supporting pregnant persons. So is this best practices? And it's not. So it's, first of all, it's discriminatory. So persons of color and poor persons are more likely to be prosecuted despite white persons being more likely to use during pregnancy. It is not evidence-based. So the risks of illicit substances are often exaggerated in comparison to the risks of legal substances, such as alcohol and tobacco. There are unintended consequences. So punitive policies drive pregnant persons away from SUD treatment and prenatal care. And engagement in prenatal care counteracts the adverse effects of substance use during pregnancy. So next section, I'm going to talk about harm reduction practices and trauma-informed care. So again, I'm not going to read every detail on these slides, but I think it's important to know about the evolution of approaches to substance use disorder treatment. So the historical approach to SUD treatment was the stick. So again, make people feel badly enough about their drug use and they'll change. People have to hit bottom and then they're ready for change. And effectively, people don't change unless they have suffered enough. So that's really an old school view. So let's look at a better approach to substance use treatment. And I call this the carrot. So people in general are ambivalent to change, whether it's with respect to substance use disorder or any other change they need to make in their life. People who use drugs continue their substance use because of their ambivalence. And so all change contains an element of ambivalence, and resolving that ambivalence in the direction of change is a key element in motivational interviewing. And motivation for change can be fostered by an accepting, empowering, and safe atmosphere. And person-centered approaches enhance motivation and reduce risk. So again, talking about the concept of ambivalence. So working to sort of counter that ambivalence and help people move that ambivalence is the key to helping people move through the stages of change, which I'm not going to go into detail about that. So it's really important that when you're talking to people, for instance, about their substance use, the counseling that you give them or the advice that you give them depends on the person's current stage of change for each substance. So mismatched counseling and stage of change can lead to a completely ineffective interaction. So if somebody is pre-contemplative about their cocaine use and you're talking to them about going to rehab, you're not hearing them. And so that person is not going to listen because you're not even hearing what they're saying and that they're not even thinking about stopping use. So that's a skill set that requires work. Recovery is individualized. And so what that means is that it's a process of change through which individuals improve their health and wellness, live a directed life, and strive to their full potential. We should not be defining recovery as being about abstinence, because that may not happen for people. So really what we want to focus on is that person getting to a better place in their life. So I think of 4 domains: health, home, purpose, and community, and often focus more on purpose and community. So people have to feel like their life is worthwhile and meaningful, and that they have a meaningful activities to do in their life in order to want to make a change. And they need to have supportive people in their life, again, to be able to make that change. So this, again, lengthy definition. It's about person-centered care. And basically that when we work with individuals, we just need to make sure that our care is always individualized. And I'm going to talk about harm reduction as a strategy employed in person-centered care. So what are some principles of person-centered care? So again, that our services exist for our patients, and so they need to be shaped by what our patients need from them. So change should not be a power struggle, and we cannot take away people's choice about their behavior. So it's important that we incorporate these aspects when we are working with patients. So components of patient-centered and family-centered care. So on the left-hand side, trauma-informed care, care coordination in all these domains is extremely important for supporting that pregnant person, their infant, and the family. And then on the right-hand side, again, with the family being in the middle, you can see how many different domains there are with respect to the needs that a family may have. So let's talk about trauma-informed care for a moment. So what are the 4 R's of trauma-informed care? So realizing that widespread impact of trauma, recognizing the signs and symptoms of trauma in people, including patients, their families, staff, and clinical team members, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and seeking to actively resist re-traumatization. So some general principles of trauma-informed care are universal trauma precautions. Again, you don't know the story of every patient in front of you until they tell it to you. So use those universal trauma precautions. The ability to adapt to how the patient is responding to the care being given, recognizing that one trauma is not all trauma, and anticipating that a person may feel shame and stigma and working around that or with that. So what is harm reduction? So harm reduction is a set of practical strategies, excuse me, and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief and respect for the rights of people who use drugs, and it is based on a strong commitment to public health and human rights. So again, a lot of words on this slide. So I just want to talk about some general principles to follow with respect to harm reduction. So substance use exists along a continuum, and abstinence is one of many possible goals. People who use drugs are more than their substance use. Their substance use is just one of their attributes. Accepting people who use drugs as they are and treating them with dignity and compassion is sure to foster a better relationship with the people we work with and help them seek care from us when they need it the most. And those are the main things I'm going to focus on that slide. So what does this mean? So if we're practicing harm reduction, what does this mean for people who use drugs? So it means meeting people where they are at. So not forcing people who use drugs to be where you want them to be and not leaving them behind if they aren't where you want them to be. Harm reduction lies on the treatment continuum. So with active use at one end and perhaps sustained abstinence from all substances on the other end and every iteration in between. So change is positive. So embrace it and encourage self-efficacy and resilience in your patients. And keeping patients alive is harm reduction. So for example, using buprenorphine intermittently to decrease heroin use, as I mentioned, that a patient might be acquiring it on the street because maybe they're too afraid to go get care in a facility. That is harm reduction as it decreases their risk of death by overdoses. So how do we identify substance use disorder during pregnancy? So universal screening should be done, not risk-based screening. So identify persons early, utilize motivational interviewing, normalize questions, embed them into the electronic medical record, use validated screening tools. So for instance, the 4Ps plus is most commonly used during pregnancy. Urine toxicology is not recommended for screening for myriad reasons. I could do an entire hour talking about that alone. Here are some of those reasons. It has a short detection window. Confirmation testing is needed. It does not capture intermittent or binge use, and it may capture one-time use. And it's often done without the patient's consent, which is not ethical. So there are also patient-provider barriers to screening. So there's the patient legitimate fear of discrimination, mistreatment, or being reported to CPS. And there's the provider lack of training, time, knowledge on how to address positive results. So what are some innovative harm reduction practices during COVID-19 and beyond? So virtual naloxone trainings, mail order naloxone and other harm reduction supplies directly to the homes of people who use drugs. And there's a hotline. So if people are using alone, which obviously puts them at more risk for an unintentional overdose, they can call this hotline number and that person will stay on the line with them. And if they become unresponsive at any point, then they would call 911. On the right-hand side is the New York State Department of Health Build a Safety Plan pamphlet that you can order free online from the DOH. This is a really excellent pregnancy and substance use harm reduction toolkit, which can be found online and is free and downloadable, and just was released this past fall. So the last section I'm going to talk about is MOUD and best practices in pregnant and parenting persons. So I addressed this a little bit when I was talking about buprenorphine. So on the left-hand side, why should we use MOUD? Because it reduces overdose deaths, period. So the more people you have on methadone or buprenorphine, the more likely they are not to die from an overdose. Just plain and simple. Naloxone does not have evidence that supports that it decreases mortality. Only buprenorphine and methadone do. On the right-hand side is showing the different mechanisms of action for full agonists versus partial agonists versus opioid antagonists. So this is referring to the pharmacology that I mentioned about buprenorphine previously. So full agonist opioids include basically every opioid that you could misuse, as well as methadone, which is a treatment for opioid use disorder. So what that means is that the more you take, the more effects you get, including euphoria and including respiratory depression, until you would go into an overdose and die if someone did not intervene with naloxone. In contrast, buprenorphine as a partial agonist only partially activates the opioid receptor. So it has a ceiling effect with regard to euphoria. So people who are opioid experienced or have opioid tolerance or dependence feel no euphoria with buprenorphine. I, as an opioid naive person, would feel some kind of euphoria with buprenorphine, sort of like an opioid light, if I were to use it. It also has a ceiling effect with regard to respiratory depression. So you could take all your buprenorphine, your whole monthly supply, and you're not going to overdose. That's very different from methadone or from other opioid full agonists, such as heroin, oxycodone, fentanyl, et cetera. And then an antagonist, which is what naltrexone is, and also what the overdose reversal medication naloxone is, does not activate the opioid receptor at all. It blocks it. And that includes, it blocks the effects of endogenous opioids, and so can lead to decreased dopamine levels and depression in some patients. So what is the standard of care for the treatment of OUD during pregnancy and postpartum? MOUD, that's it. MOUD with methadone or buprenorphine. Pregnant persons actually do not need to meet DSM-5 criteria for opioid use disorder to receive MOUD. Any opioid use in pregnancy, the recommendation would be to treat with methadone or buprenorphine. This is what is endorsed by basically all professional medical organizations. Access to behavioral counseling is an adjunctive treatment if needed. It is not required. So whatever conversation / counseling that patient has with the provider who is providing them with the MOUD is adequate, as long as the patient doesn't express an additional desire or needs. And then, of course, the person could receive additional counseling as needed. So as I mentioned, most pregnant persons receive not only no SUD treatment, but even if in SUD treatment, do not receive pharmacotherapy. So unfortunately, the rates are like less than 50% who receive pharmacotherapy, despite it being the standard of care and best practices. So there is no role for medically assisted withdrawal or detox for OUD during pregnancy. So to quote ASAM, the American Society of Addiction Medicine, withdrawal management has been found to be inferior in effectiveness over pharmacotherapy with opioid agonists and increases the risk of relapse without maternal benefit. neonatal or maternal benefit. So there are increased rates of neonatal opioid withdrawal syndrome for persons who go to detox, again, because of relapse rates. And also that pregnant person is at increased risk for fatal overdose, not being on MOUD if she relapses. And also what we've seen is for pregnant persons that are only going to detox and not on MOUD, they have fewer OB visits attended and fewer in-hospital deliveries. So what are the benefits of MOUD in pregnant persons? For the pregnant person, there's a 70% reduction in maternal overdose deaths, which is enormous. There's a decrease in acquisition and transmission of infectious diseases, increased engagement in both prenatal care and substance use disorder treatment, and improved maternal outcomes. For fetal benefits, there's a decrease in fetal stress, again, because they're not experiencing a withdrawal, which someone would have if they were using opioids actively. There's a decrease in intrauterine fetal demise, a decrease in intrauterine growth restriction, and a decrease in preterm delivery. What are the goals of MOUD? So as I mentioned a little bit earlier, to decrease the risk for both fatal and non-fatal overdose, eliminate opioid withdrawal syndrome, decrease opioid cravings, increase patient functionality, try to normalize those changes in brain anatomy and physiology, decrease the risk of infectious diseases in persons who are using drugs. There are 3 FDA-approved medications for the treatment of opioid use disorder. I've mentioned them all already: methadone, buprenorphine, and naltrexone. So let's compare methadone versus buprenorphine. They're both pregnancy category C. Methadone was the traditional gold standard. Really, buprenorphine has surpassed it as far as both outcomes and as far as retention and care. Some neonatal outcomes are better with buprenorphine. Again, methadone would need to come from an opioid treatment program specifically, whereas buprenorphine can be done in any setting by a provider that has a DEA-X waiver. So what are the best practices according to the New York State Department of Health and OASAS with respect to prescribing buprenorphine? So continued access to buprenorphine even in the absence of counseling. Ensure immediate and continued access to buprenorphine, even if people are unwilling to attend counseling or any other psychosocial services. Not discharging patients solely because they're using either other prescribed or unprescribed substances such as benzodiazepines and cannabis. Continued access even in the presence of ongoing drug use. And again, it's important that providers think about diversion, but as I explained, the reasons why diversion occurs and why people acquire it on the street, again, it's important to be aware of that. But for example, what had come up with me, if a patient talked about a family member who they had shared their buprenorphine with, I would say, why don't you bring in that family member and let's get them their own prescription? Because again, most people who are acquiring it are doing it to treat their own opioid use disorder. So MOUD should happen during pregnancy, during intrapartum care, and postpartum. Again, I'm getting close to running out of time, so I'm going to just quickly address this here by just saying during pregnancy, dose may need to be adjusted, particularly in the 2nd and 3rd trimesters due to increased metabolism and increased blood volume. Intrapartum, dose should be maintained of buprenorphine or methadone. And then if they have acute pain issues related to the delivery, that can be managed with full agonist opioids in addition to their baseline buprenorphine or methadone. And then postpartum, continue the same dose of prenatal buprenorphine or methadone. Again, that's a stressful period. So you want to let the person who delivered be guiding you on when they feel ready to decrease their dose. Down to maybe the dose it was prenatally. So again, I've mentioned a couple times that it's a stressful time in the postpartum period. It's a vulnerable time for people who have delivered and their babies and their families. So it's really important that that continuity of care be maintained. 40% of persons who give birth don't ever go to their postpartum visit. So often the only provider that has continuity of care is the person doing MOUD with them. So I often get asked, how long should people remain on MOUD? And really, it's important to think of it like you would for a patient who has diabetes or has hypertension. So think long-term or lifetime for patients, but not short-term for them, because the opioid use disorder is a chronic disease, and they may maintain their medication for the rest of their life. They may be on it for many years. The average is 8 to 9 years. And then maybe things have changed enough in their life that they're able to taper off of it and be off of it. They may go on and off of it depending on things going on in their lives. But again, that needs to be individually tailored, and it should be guided by your patient and not by the goals that the provider has of having people off by a certain time frame. And we know that overdoses go up. People have a high recidivism rate to relapsing with opioids after they are off medication. So we don't want people to be unnecessarily at risk. Couple words about NOWs. So the mother study looked at outcomes at 36 months for children who had been exposed in utero to either methadone or buprenorphine, and they did not find any detrimental effects to any form of their development that they were tracking. With respect to breastfeeding, breastfeeding can occur with both methadone and buprenorphine. It's an important aspect actually for preventing NOWs, because that touch and skin-to-skin contact that happens with breastfeeding actually decreases the infant's risk for NOWs. So as I mentioned a couple times, NOWs is an expected and treatable consequence of opioid use in utero. It's not predictable what infant will develop NOWs. It is not associated with the dose that the pregnant person is on of either methadone or buprenorphine. So that's definitely a misnomer that people think it's associated with the dose, and it is not. There are individual characteristics in the infant that will determine whether that baby develops NOWs or not. So, what are some things that we can do for pregnant persons with SUD to address their needs? So I think you can see throughout this whole presentation that they have a really unique set of needs across multiple domains that affect both their obstetric health outcomes and their SUD treatment. So ideally, all of these needs could be addressed in a co-located integrated services. Sometimes that's not able to happen. So again, it would be with a warm handoff to other supportive services. So what does Acog say about opioid use and opioid use disorder and pregnancy? Obstetric care providers have an ethical responsibility to their pregnant and parenting patients with SUD to discourage the separation of parents from their children solely based on SUD, either suspected or confirmed. So I think it's really important that we try not to discriminate or criminalize folks who are struggling with their substance use during pregnancy. The best way that we can have outcomes that are good for both the pregnant person and for the baby is to actually warmly engage them in care. So just a few conclusions. As I stated, there's a complex milieu of factors that underlie substance use disorder in women. Understanding the principles and practical application of person-centered care, harm reduction, and trauma-informed care leads to better outcomes in our patients. For pregnant persons with SUD, engagement in prenatal care improves outcomes regardless of substance use or engagement in substance use disorder treatment, and decreasing stigma increases engagement in care. Pregnant persons and parenting persons with SUD experience discrimination and scrutiny on an unparalleled level. MOUD is the standard of care for all persons with OUD, including pregnant persons. Care ideally co-located, multidisciplinary, non-judgmental, and patient-centered. If not co-located, then, as I said, a warm handoff facilitates care engagement. And remember, substance use and/or SUD in and of itself is not an indicator of child abuse or maltreatment or neglect. And then these are some OASAS resources on opioid overdose prevention. So I am gonna share these slides. I'm gonna stop sharing, and I know we're at 11:03. I can stay on for a few extra minutes. And if there are any questions that I don't get to, I'm happy to respond to them via email.
Actually, thank you, Dr. Ramsey, for your very comprehensive presentation. Very important content, and being with us here today. We so appreciate the inclusion here of your presentation within the MomD webinar series. So, right, we will continue to stay on for a little bit longer, and thank Dr. Ramsey for being able to stay with us. Before moving on to Q&A, we want to ask one more question regarding the material of this webinar series. So we want to, again, use this webinar series as a way to bring together professionals in the field of perinatal mood and anxiety disorders and to grow this network statewide. And if there are any topics you'd like to see in this webinar series, please add them to the chat now or before logging off at the end of this discussion. So right now, we'd like to open up then to take any questions. Feel free to share, start your video and unmute yourself. Or
there's one question in the chat box, so I'm going to address that one first.
Thank you.
So, do you have any concerns about legalization of marijuana, its use during pregnancy? So, the data is pretty conflictual on the effects of marijuana during pregnancy. We do know that marijuana use has increased as shown by my data, particularly in non-pregnant persons, but again, it has fluctuated in pregnant persons as well. I think it's way too early to say kind of what to anticipate in New York State. Certainly, I think that New York State, in its law, the law that was just signed by Governor Cuomo, has been thoughtful in the approach to taking to the legalization of marijuana, with protections and education and prevention that are being put in place. So we're not going to see any effects of the program for at least a year. So I think in a year, I'll be better poised to see how it's affected treatment in New York State, how it has affected, for instance, pediatric exposure to marijuana, et cetera, et cetera. And I just think we don't know yet. If we look at the experiences of other states, though, I would anticipate we'll see increased use. But that's probably all I can really say about that. Happy to take any other questions. I know it was a lot of information in a short period of time. So I apologize for that.
Dr. Ramsey, would you have a suggestion? I mean, there's so much material, a lot of great resources that you provided to us today. I mean, with there's so many takeaways. What we say, how we say matters. Really, you connected the dots to so many different areas. But if each of us were to do just even one thing to start to make a difference, that we could share particular resource information, embed something into our practices, what would you suggest? Where do we start?
So for the one resource, I would go to the harm reduction and in pregnancy substance use toolkit. I would definitely go and download that. I think that has great information. I think probably the most important takeaway for me, just sort of in my many years of working with people with substance use disorder, is that remember that person in front of you has a story and they have to trust you in order to share that story. So, I've heard from providers sometimes who aren't familiar with working with people with substance use disorder, well, they lie or they do this or they do that. And it's sort of, people are protecting themselves. And if they've experienced stigma multiple times previously that they're anticipating that response, and they're experiencing a lot of internalized stigma. And so they're not going to be forthcoming with you, and they are not going to share their story with you. And you're not going to know sort of who that person is until they feel they're in a safe enough space to actually share that with you. So if you approach everybody in that way, you're more likely to get information about them from them that can help you to take better care of them. That's probably what I would say.
Thank you.
So there's one other question, care plans. So care plans are really important. So just as an FYI, the Capta Cara federal legislation, it's well-intentioned, but if not implemented well, it could actually end up being stigmatizing and discriminatory against pregnant persons. So the New York State Department of Health has worked with OASAS and OCFS to develop an implementation process, which is going to be happening imminently. And they're going to be webinars about the plans of safe care. So there are very clear indications when you have to do a plan of safe care. So yes, I think it's important that the person who knows that pregnant person does the plan of safe care with them, because then the patient's going to be involved in it, and you're going to make it important and relevant to that person and their infant and family. Whereas if that person needed a plan of safe care, goes into the hospital, and their substance use disorder, for example, is discovered at delivery, then the hospital, who really just met that person and doesn't know them, is going to be the one doing the plan of safe care. And then it might be done in a perfunctory manner that really does not have practical application for that person's life. Whereas if that person goes into the hospital with delivery with their plan of safe care in hand, it's taken care of. And so the letter forthcoming from the Department of Health and the webinars will address exactly, it's going to talk about stigma. It's going to talk about discriminatory practices in reporting. It's going to talk about, I'm actually presenting a webinar on plans of safe care. So that webinar will be one of the webinars, and then on reporting requirements, and then sort of the background on Capta Cara. So what I can do is forward that information when it's publicized to you guys, so that that everybody is aware and can attend those webinars. But yes, I would say if your patient needs a plan of safe care, develop it with them so that it actually is meaningful.
So are there any other questions? Okay. So Dr. Ramsey did provide her contact information, so feel free to reach out to her after this webinar at any time. And Dr. Ramsey, again, thank you so much for this, this great presentation, and that you really have helped to increase our knowledge on how to better help and support birthing persons, moms in New York State who suffer from addiction. And that will further help us to prevent maternal mortality also. So thank you again to everyone, and have a great day. Thank you.